all have relationships, and expectations are important. And it's always important to kind of undersell and overdeliver. Hate to use business terms, but it's true. I think if you give a low expectation, but you then overdeliver, that's better than overpromising and underdelivering, because it's one thing to have a complication or something go wrong, and it's another thing for the patient not to have any sense that it might happen. I had a middle-aged gentleman who was morbidly obese. He was probably about 350 pounds, and he had a complete Staghorn renal calculus. This guy, he's indigent, didn't have a lot of resources. In fact, he took the bus to get to my clinic. His access to care has always been challenged, and hence he probably had a kidney stone many years ago and probably sat on it, and next thing you know, it's his complete Staghorn renal calculus. And so I gave him his options, and the best option typically is a PCNL, percutaneous nephrostolothotomy, and I tell him it may take more than one procedure, but oftentimes we can get it done in one procedure. So we consented him for the surgery. We did the PCNL and took him to surgery, but he didn't have a good outcome. I had difficulty getting access. I couldn't get access into his kidney, and then during the attempts to get access, he started developing respiratory problems, and we had to abort the case, and I do all my cases on a prone position. He clearly was not tolerating the prone position, so we had to wake him up and abort the case. It's a horrible feeling to go and tell the patient as well as the family. It's kind of what I call the walk of shame. You go and say that, you know, the patient's okay, but the surgery was not a success. And there's always that look of disappointment by everyone, mostly the patient, like, what, you didn't get it done? You know, I went through all this for nothing? And it's like, no, you didn't go through for nothing. You know, number one, you're fine, which is the most important thing, but number two, I'll get this done, I will take care of you. It's just gonna probably take another procedure. We're gonna have to come up with a plan B. So plan B was staged ureteroscopy, and as you probably know, it's often not the first line treatment according to our AUA guidelines, but it is an option in the most recent guidelines. And because of his inability to tolerate the prone position, I discussed with him that, look, we're probably going to go up there perhaps 2, 3, could even be 4 times over the next 4 months to render you stone free. So instead of doing 1 procedure or 2 procedures, you're going to have multiple procedures. And unfortunately, you're going to have a stent in between each time, letting a lot of the fragments pass over a several-week period. And as you know, stents are uncomfortable. So although this is a less invasive procedure, you could argue it's actually more invasive in some ways because of the stent morbidity. I felt bad for the guy, you know. So we took him back for ureteroscopy, and whenever I have a Staghorn or a large stone that I'm going to do dusting, I typically do put up an access sheath. I love access sheaths for this reason, because you can irrigate, it improves visualization. A lot of the fragments will then pass down alongside the scope. I think it really expedites the procedure. It also decreases pressure, backflow. If there's any potential infectious risk, I think that infectious risk might be mitigated by using an access sheath. And then I take the laser settings and I use a dusting type setting, which is like a low 0.2 joules, and I ramp up the rate to about 40 or 50 hertz. And we just sit there with the scope and just go to town. There's no basketing. I don't like to laser for more than 2 hours, especially a large stone that I think that might be an infectious risk. I think it does increase their risk of perioperative infectious complications. So with the access sheath, limited operative time, get in, stent them with a plan to come back. And I always lower the expectation. I tell them it's going to take several procedures here, okay? So after I did my post-op CT, I was surprised to see that he didn't have much stone. Oftentimes, a lot of these indigent patients, as you probably know, compliance and coming back is a problem. And here's a guy who's morbidly obese. He doesn't have a lot of access to care. He takes a bus every time to get back to my clinic, and he follows up every time. And he's lost weight. He's reduced his risk factors for stones, and he hasn't formed another stone. I've repeated the CT, serially, and he's had no stone recurrence. So every time I see him, it kind of brings a smile to my face, because I feel he's a success story on so many levels, really. So I think the take-home message is twofold. Number one is communication, and really making sure that the patient has a realistic expectation. Because I think when patients get upset when the expectations are mismatched. What they expect and what I expect are different. And number two is not underestimating the technique of dusting. I was early on in my learning curve of that, and I was really shocked by how effective dusting was for a kidney stone.